All right, our last speaker of the morning is Dr. Nick Hanamiya. Dr. Nick is a specialist in primary care sports medicine. He has particular interests in diagnostic and interventional ultrasound, preventative medicine, and exercise as medicine. Dr. Hanamiya earned his medical degree from Western University of Health Sciences and then completed a residency in family medicine at Stanford Healthcare, serving as chief resident and completing the faculty development track. And then at UCLA, he completed a fellowship in primary care sports medicine. He's also the team physician for the Oakland Roots. Dr. Nick.
Nick's got an online poll, so we're going to put his computer on here. Just one sec.
All right. Well, thanks everyone for being patient with my neediness and technical demands, I guess. I wanted to try to make this as interactive as possible. That led to you all hopefully getting a good stretch break or maybe practicing some yoga after Alyssa's talk. Really happy to be here. Thanks for the invitation. We're going to shift gears quite dramatically from some of the morning sessions and going to be talking about dermatologic conditions in athletes. And as a primary care sports medicine physician, when I work with athletes in the training room or on the sidelines, while I do see quite a bit of musculoskeletal injuries, I surprisingly see quite a bit of derm things as well too. And so hopefully this will be useful for all of you that see athletes. I have no relevant disclosures, but I do want to acknowledge Dr. Josh Goldman, who's my colleague at UCLA, who allowed me to use and adapt some of his slides from his talk, which he likes to call the itchies and scratchies. So we will go ahead and proceed. As I mentioned, I wanted to try to make this as interactive as possible, and so I'm going to be using this platform called Poll Everywhere. So if you don't mind taking out your smartphone, or if you have a computer, you can go ahead and scan that QR code or send a text message to the number there or go to that link. You don't have to download an app or anything. I don't know if they're going to steal your information, hopefully not, but give you all some time. Looks like you are all able to do that. Great. So we will test this out. So I want you all to type in what dermatologic conditions you may have seen in athletes. And I can't see it on my screen, but I'm just going to peek over here. Oh, cool. You can put emojis. That's nice. Oh my gosh, it's going a little crazy now. Okay, but I think I saw a ringworm, I saw maybe turf burn, impetigo on there, a whole slew, candida I think I saw on there, so a whole bunch of different things, which is really great. So hopefully we'll be able to talk about a lot of those things that you all put there. So for objectives by the end of this talk, hopefully you'll be able to identify some common dermatologic conditions in athletes, know the different treatment options that are available for these, as well as the return to play guidelines, which I think is the most important and perhaps the most unique thing about working with athletes, thinking about when can they go back to sport and what things need to be done. Before we dive into it, I think it's really important to talk about some background, specifically talking about terminology. I think this is unfortunately becoming a lost art. When I was a medical student, I remember a resident telling me when I was looking at a fracture that you should have the words to be able to describe to somebody what the fracture looks like without looking at the x-ray so that they can visualize what that looks like, right? The same thing is true with rashes, and I think with our clinical documentation before the invention of EMRs, we had to really know our nomenclature to be able to describe what the rash looks like. And so if you were talking to somebody on the phone about it, you could describe it and they could visually kind of, imagine what that looked like. But I think with photos, it's really easy just to take a photo and put it in the chart, so it's becoming kind of a lost art. But thinking about the way the skin lesion looks, and those are some terms there just as a reminder of how you can describe it. You can also describe the color, right? So if you don't know those fancy words or terminologies, just describing what you're seeing in terms of the color can be helpful. Specifically whether there's erythema or redness, or if it's hyperpigmented, so darker, hypopigmented. And then also looking at the morphology, so describing what it looks like. Is it more round and annular? Is it perhaps more net-like and reticular? Or does it follow specific dermatomal patterns, right, or the distribution of it? And then I also think it's important to think about the sport that the athlete or patient is participating in. This is from a review article that's a little older, from 2012, but they looked at all the different skin manifestations in Olympic sports and kind of looked through the literature. And it probably looks really tiny on the screen, but they basically broke it down by sport and then different types of things to think about. So environmental exposures, whether they're outside playing or if they're in water, different things that might be unique to the sport, like cycling, for example. You think about more friction type things that might occur, and then certainly different bacterial or viral etiologies that might be more unique to the individual sports, which we'll dive into in the future. So just, kind of some food for thought. All right, so the first category we're going to talk about are viral infections, and we'll start with a case. So this is a 15-year-old high school wrestler who's coming in with 2 days of a rash on their chest. They have some associated subjective fever chills, maybe some lymphadenopathy and body aches. Several days prior, they said they felt like their chest had some increased sensitivity, like that their shirt maybe was chafing there, but they didn't really see much. No sick contacts, no recent exposures, no travel, no other people with similar lesions, but they send you a photo or show you something that looks like this. So, using the terminology that we just looked at, to me this looks a little more vesicular, perhaps clustered together, localized to a specific area, maybe a little erythematous base or redness on the bottom. So what criteria must this athlete meet before returning to play? So go ahead and see. So is it A, must be on appropriate medication therapy for at least 120 hours, must have no new lesions in the past 72 hours, no systemic signs or symptoms, can cover the area and then go back to play immediately, or you're okay to go back and play? What do you think? I can't see the responses. And these are tough questions, I recognize, so. Okay, so from what I saw, it looked like and it's multiple, it's select all, so there's multiple right answers here. But a lot of you picked must be on appropriate medication therapy for at least 120 hours, no new lesions in the past 72 hours, no systemic signs or symptoms, and then can cover the area. So this is actually a herpetic lesion, really common to see in contact sports that involve skin-to-skin contact, so wrestling and rugby particularly. The infectious agent usually is herpes simplex virus 1. They will have tingling or itching as a prodrome, but sometimes your athlete may not recognize what that is, and it could be like I described in that clinical case where they may have like increased sensitivity they describe or feel like that chafing sensation. Then they will develop those lesions that can be painful, that are very characteristic with clustered and vesicular, meaning fluid filled, and have that erythematous base. And then as they progress, they may blister or pop over, and then you get some erosions and crust there. For diagnosis, it's really clinical, but if you really want to, you can do something fancy called a tank smear. And treatment is really using antivirals. So oral valciclovir is really the first line that we do. And then, thinking about whether this is a recurrent infection, you can adjust your treatment accordingly. And then in some athletes, if they have a lot of outbreaks, you can consider putting them on suppressive therapy, right? So if they have a big meet coming up and they're worried that they're gonna get a lesion and they don't wanna miss that competition, you can certainly put them on a prophylactic dose. So getting to the answer to that question, for return to play, they can't have any systemic signs or symptoms, so like the lymphadenopathy, the fever chills, or the myalgias. No new lesions can be present for the last 72 hours. They must be firm and have an adherent crust over it. And they have to complete a minimum of 120 hours, that's 5 days of the antiviral therapy. And unfortunately, they cannot cover it to be able to participate, right? So that's important. With some of these, they can, but with herpetic lesions, they cannot cover it. So it has to have that firm crust over it before they're able to return. All right, this is our next viral rash that you're looking at, and I don't know how clearly it shows up there, but what I see here are some small scattered papules, perhaps a little erythematous with some, you'll notice central umbilication, so in the middle it kind of rolls in. Any thoughts, or you can think in your head what this might be? Yeah, great. Molluscum contagiosum. So also can be seen in wrestling. Swimmers can get it as well. You will see it a lot on the torso, but can be present on the face and hands and thighs. They're painless, so they don't really cause much discomfort, but the hallmark sign is those pedunculated lesions, right? So those kind of dimpled lesions with that central clearing. To treat this, you could do cryotherapy, so like using liquid nitrogen over the area. You can curette them. And then there are some other solutions that you can do. And then once you curette them or cryotherapy them, you can cover them and they can return to play. Okay. All right, and how about this? Yeah, I heard plantar wart. Great. So what I see here is the sole of the foot, a little hyperkeratotic. So you can see the skin's kind of built up over that area. It looks very well defined, perhaps a plaque or even papules that are there. So this is a plantar wart or a verruca, and it is usually seen in contact activities. You can see it in weightlifters, often on the hands or on the soles of the feet. They can be a little discomforting depending on where they're at and how often the athlete is having any contact or friction over the area. On appearance, as I mentioned, they'll be well defined and have that like plaque or papule type appearance. And then sometimes if you pare it down, you'll see a little pinpoint hemorrhage or a little dark spot in the middle, which is where those capillary beds are that feed that area. And then treatment is you can excise it or pare it down. There's cryotherapy or the liquid nitrogen, and then salicylic acid or a lot of over-the-counter things that they can try. And there's no need to restrict them from play if they have any of those, okay? All right, so now you're experts in the common viral things. We're gonna shift to some bacterial infections. So we'll start with another case. So a 17-year-old lacrosse player is coming with concerns of some pits and dark spots on the soles of their feet over the last several weeks. It does coincide with them playing more lacrosse recently and spending more time in their cleats. They've also noticed some malodor, which they didn't have before. And it is a little uncomfortable, but not super painful, but they do describe a little mild pain. It's not spread anywhere else. They have no lesions in any other locations, no new exposures or no systemic symptoms. And they send you a photo of something that looks like this. So I see on the sole of the foot, maybe some hyperpigmented areas that are scattered. You might not see it well on the screen, but there's actually like little pits or dimples there, okay? So how would you approach treating this? So A, avoid wearing cleats and encourage use of synthetic or socks or moisture wicking materials. Just monitor, no need for specific treatment. Refer to their dermatologist or use topical clindamycin. Again, I know these are really challenging, but. So it looked like a vast majority for A, some for C, which is appropriate if you don't feel like you are able to recognize what that is, and then some for D, I think, which was topical clindamycin. So this I remember learning, and I was like, I'm never ever gonna see this, but I've actually seen it quite often in athletes, more than I would have expected. So this is pitted keratolysis caused by Corynebacterium or the Micrococcus species. What you see is you see maceration on the bottom of the soles, often on the heel, usually when they're exposed to an environment that's more moist and occlusive, right? So they're not really getting that area aired out, so to speak. You see it a lot in closed shoe sports, so thinking about tennis or basketball. I've also seen it a lot in lacrosse players, which is why I gave that case, or soccer players, especially if it's in a more rainy time when they're in those shoes and it's really wet outside. They'll have those discrete pits and then also have some malodor. And often sometimes athletes might be really embarrassed because their feet smell, right? And so they won't want to bring it up. But if you look on the bottom and you see that, you can tell them, hey, it's not your problem and why your feet, you actually have something going on that's causing that, right? So treating this is quite simple. You can use topical clindamycin or erythromycin that they can apply on the bottom, and they can continue doing that for several weeks. And then to prevent this, it's really encouraging them to wear synthetic socks and avoid prolonged occlusion in their athletic shoes. All right, this is the next bacterial dermatologic condition, which I think was a common one on the word cloud there. So for this, I see it's on the chin. You can see some erythema, some yellow honey-colored crusting that's there, and maybe some pustules as well too. So this is impetigo. This is caused by staph, but can also involve strep. You'll often see it on the head, neck, and can be present on the extremities. It can be scattered, but they'll have focal pain kind of right over that area. In its early stages, it'll just be more erythematous with some pustules, and then once it really blossoms, then you get that more well-defined area where it's kind of contained to with that classic characteristic yellow honey crusting. And for those of you that have young children, you may have also experienced this with them. Treatment is really just topical treatment for this. Topical mupirocin is really the go-to. And for return to play, they have to have been on treatment for at least 72 hours and no new areas for about 48 hours. And this is also one that they cannot cover, so they can't cover it before they're allowed to participate. All right, and then our next one is this photo. So for this, I see some scattered pustules. It looks like that they're pretty localized to where hair follicles are coming out, maybe a little bit of erythema kind of along the skin or the base there. So this is a folliculitis, so an infection or bacterial infection of that hair follicle. We often think of staph as well as strep. It can be related to skin trauma or skin-to-skin contact. See it a lot in basketball or football players. It'll often appear as painful perifollicular pustules with that erythematous base, and sometimes they can have tender or fluctuant nodules as it progresses. And when I was a med student, I was always really confused about what the difference was between a folliculitis, a furuncle, a boil, a carbuncle, an abscess. Like, aren't they all the same thing? And the answer is yes to some degree. It really depends on how deep the infection is and where it is, right? So when you're thinking of like a pimple or a folliculitis, it's really just isolated to the more superficial layers where that hair follicle is. If you go into the deeper spaces, then you're thinking about a furuncle. And if you have a collection of those together, then you get a carbuncle. And if it gets even deeper, then you can think of an abscess. I think it's really important to acknowledge that while staph can be one of the main causes of this, and it can also be resistant to some medications that we used to commonly prescribe. And there was a big increase in the early 2000s, which I think some of you may remember. I think just in terms of hospitalizations from the community spread of this methicillin-resistant Staph aureus, but then also in our training rooms and with athletes, right? We had to be really diligent about cleaning everything, in which we still are. And the recurrence is usually related to colonization. So a lot of us just have Staph aureus as part of our native skin flora, so we're colonized with it. If they do have recurrent infection and it's really problematic for them, they can try doing a decolonization, although that can be quite challenging. And you have to use the mupirocin in their nares pretty frequently, and then you can do a chlorhexidine wash. So it is quite involved. For treatment of this, it really depends on what your suspicion is in terms of how it looks and whether the area that you're in might have a high incidence of MRSA versus not. If you're thinking about like a sensitive Staph aureus, you could try Keflex or cephalexin. And then if you're thinking more of MRSA, then I usually will start with something like Bactrim, or which is the TMP SMX on there. And then if it is an abscess and it's fluctuant and amenable to an IND or an incision and drainage, then we usually will proceed with that. So using like a scalpel to lance or break the abscess to promote draining. Warm compresses can also be really helpful to try to make sure that if it's really firm, that it gets more fluctuant so that it can drain. As far as return to play, they must have no systemic signs or symptoms. So if they had, fevers or anything associated with that, they cannot have that. No new lesions in 48 hours. If it is like an abscess or something that's draining, they must have no drainage or exudate coming from that. And they have to be on antibiotics for at least 72 hours. And you also cannot cover this for them to go back. In a similar line, some of you may have seen this. This is something that's more, it looks like, contained to the superficial layers of the skin, some erythema, maybe a little more well demarcated in terms of the borders. If you feel it, it might feel a little more warm or hot compared to the opposite side, and sometimes it can even have a little bit of superficial swelling there. This is a cellulitis, and this can be caused by a bunch of different organisms, but we really think of strep or staph. The treatment is similar to what we talked about on the previous slide, so either Keflex or Bactrim, and there's a bunch of other things there. I try not to use Clinda as much just because of the GI upset that it can cause, so I usually start with either Keflex or Bactrim. And then similar in terms of return to play, I usually wait around 72 hours. What's helpful for a cellulitis is if you have like a skin marker or something to trace around the outline, that's really helpful because you can monitor that while they're on their therapy to make sure it's not spreading and it's actually receding back. And athletes usually like doing that. They think it's kind of fun just to trace it and monitor it over time. Okay, now we'll move to fungal infections. Here's another case. 16-year-old high school football player presents with a small red spot that has raised borders on the upper arm. Thought it was dry skin initially, but became more red and increasingly more itchy. It hasn't spread, no other symptoms or no exposures, and then you see something like this. All right. Lots of head nods. Have you seen this? Maybe common. Yes, I'm seeing well-defined annular, so round area of erythema with an area of central clearing with some rolled borders on the side. So when may this athlete return to play? So upon completing a course of topical or oral antifungals, must be on antifungals for at least 72 hours and the lesion must be covered. After the lesion's covered, or it cannot return until the rash is fully resolved. All right. It looks like B is the winner right now. So this is tinea corporis, also known as ringworm. You can see it in wrestling, but in that example is a football player. The infectious agent is a trichophyton, and on appearance, you'll really see what that photo showed, right? That well-defined annular area, round area of erythema with some scaling plaque in that central clearing. To diagnose it, it can be clinical, but if you really want to get technical, you can do a little scraping and then look under a microscope with KOH to see if you can see the pseudohyphae there, which is characteristic of a fungal infection. Treatment for this, you can do topicals, and for topicals, there's a whole bunch of things that you can try. To return to play, they have to be on it for at least 72 hours, and you can cover it after too, okay? This is similar, but just in a different location. So this is on the scalp, but has a similar appearance to the one that we saw previously. Just in nature of it being in a different location, this is tinea capitis. So it's still tinea, but that was on the scalp, so it's on the head. And similar appearance, but with the scalp, you'll see sometimes alopecia or an area where the hair isn't growing anymore. Similar diagnosis can be clinical. You can also do the scraping. However, for this, we usually use oral agents only. So the treatment is a little different, whereas we use topical for the skin one. For this, typically we'll use oral agents. Greaseylfulvin is usually the one that we'll start with. And it's a little longer return to play, so they must be on it for a minimum of 2 weeks before they can return back to playing. And then this is on the bottom of the foot. Some of you may have seen this, quite common. This to me looks like an area of perhaps maceration, but dry, scaly on the inner digits of the toes. So this is tinea pedis. So this is a fungal infection, or athlete's foot we commonly call it. It's caused by trichophyton. You can see that fissuring that's there. It often is quite itchy for them. Treatment for this, you can use topical or oral, but usually topical is the first line, and you don't have to remove from play, so they can continue playing with this and treat it accordingly. All right, I think this is the second to last section. We'll talk about parasitic infections now. So another case, 14-year-old soccer player coming with an itchy rash over the body. Not sure what caused it, but did travel with their family to Minnesota and spent a lot of time swimming in all the different lakes that we know Minnesota has. Started on the legs, didn't spread, and then spread to other parts on the body, and is very itchy, but has no other systemic signs or symptoms, no contacts with similar rash. And then you see something like this. So like scattered areas of erythematous, maybe papules hard to see, or patches if it's more confluent. Maybe there's some excoriations because they said it's really pruritic or itchy. So what are the next best steps in management? You can select all here. So A is topical steroids, B, oral antihistamines, C, isolate until the rash is gone, or D, topical or oral antibiotics. Are pretty good. So B looks like the winner as well as A, so oral antihistamines or topical steroids. So this is called swimmer's itch. I remember another one I learned, I was like, I'm never gonna see it, and I've actually seen it quite often too. The way it actually occurs is a little gross to some people, but it actually is from this larval trematode. So on the diagram there, you can see that it's a parasitic thing, but essentially there's a bunch of different hosts, and we're, as humans, just subjected to the larva getting confused, thinking that we're a host and trying to come and reproduce, and it causes just infectious, or it's not infectious, but really just an allergic reaction more. So that's why it's often really pruritic and can spread over the areas. So they may start with just some mild itching in the beginning and then develop that rash that I showed on the previous slide. The rash can actually continue for about a week, but the treatment is just really conservative. So, trying to control the itching with oral or topical antihistamines or hydrocortisone cream. It's non-communicable, so if they do have this and the history kind of lines up, then you don't have to worry about that spreading. And then usually after a few days when they're on the antihistamine, the rash will start receding and they no longer have itching and they feel a lot better. Okay. All right, how about this? So the picture is a little hard. This is on the knuckle. So I see areas of erythema with maybe some lacy patterns or lines, burrows perhaps. So this is scabies. So this is something that's spread through skin-to-skin contact. You'll see those erythematous papules in those characteristic linear burrows. It's usually in areas such as the inner space of your fingers, can be in the axilla or even in the toes. Usually we'll spare the head and the neck area. They do have lots and lots of itching, but typically that's worse in the evening times. To treat this, they need to do a full body permethrin cream, and then they can wash that off after 8 to 14 hours. You should also treat their close contacts and then decontaminate household things by washing them and then drying them in high heat. For return, they can actually return around 24 hours after treatment, and then you can do a specific prep to look for scabies, although treating and just monitoring clinically sometimes is sufficient. This is the next one. This is in the scalp, so you can see these are nits in the scalp. So this is head lice, which I think we still see quite often in some athletes. Transmitted by direct contact, you'll see those nits in the hair. They may have some inflammatory papules or some little red spots on the scalp itself if you look a little bit closer. You can remove the nits by using a comb, and then you can also you should launder everything with high heat, similar to how things were with scabies. And then you can use a topical shampoo. They can return after 24 hours of treatment, and then you should reevaluate them to confirm that everything's been removed. Yeah, let's see. That was I don't know, was the video playing on there? Yeah, oh yeah, I didn't see it on my screen, but that was a video that I took when I was a resident and had a lot of time for some reason in clinic and looked under a microscope and thought it was cool, so I've kept it in my slides since then. All right, in the last few minutes we'll wrap up. We'll talk about some non-infectious dermatologic issues. So for this is something that I've seen often as well. You can look at that. It looks like an area of hyperpigmentation that's pretty well confined on the sole of the foot. You can often see it on the heel as well. This is talon noir, also known as black heel. It's in athletes that do lots of sports that do stopping and starting a lot, so lots of friction. I had this when I was younger when I played soccer. It was on the back of my heel and I was freaked out what it was. But really what happens is you get a little bit of hemorrhaging underneath that area, and it can present in that way. To really diagnose it, if you're eager, you can do like a skin scraping and then look for occult blood, and that'll be positive, but rarely do we do that. One important thing though is to make sure you know your A, B, C, D, E's of melanoma and whether or not you're concerned about that, but it's often mistaken for that. So that's where your history really comes into play and thinking about the location of it. And this you can just monitor, no need to really intervene unless it's causing a big issue. And then this is quite common, I think, for all of our athletes, blister that's there from repetitive friction, thinking about what equipment they're using or ways that they can modify their activities to prevent this from happening can be one thing that you can do. Some prophylactic things is also thinking about how they're breaking in new shoes. You can use lots of things to cover the area, like second skin or new skin is quite common in training room settings, but moleskin can be another option for you. All right, so we made it. So in summary, these were all the different conditions that we actually talked through. I think these are some of the more common ones that I see on a day-to-day basis with athletes, and then also, honestly, just with family and friends sending random photos of rashes and who knows what location that you can't make out on the picture. I will draw your attention to some resources. So in California, the California Interscholastic Federation has a skin form, so any athlete that has a rash, their provider can fill this out, and then you document where the rash is. They also have some guidelines. I will say that the guidelines for high school, NCAA, and all different leagues are very different, and so looking at what organization the athlete is playing for and following those guidelines will really be your go-to. But the CIF has a bunch of different common things that are listed and how they recommend treating it and the recommended return protocol. For the NCAA, they also have a skin form. You'll notice it looks exactly the same to the high school one, except I think when you get in college, you grow hair right on there. But otherwise, they have the same thing where they list everything out. And then I'll draw your attention to the NFHS consensus guideline. That's a really great resource too to take a look at if you want to just reference something from this talk and you're like, I don't really remember. That's another thing that you can take a look at. Those are my references, and then I think we're just on time for questions. And then Come Watch the Roots are our home openers today at the Coliseum, so excited for that. So go Roots. Thank you all.